this specialty of pathology is absolutely linked to clinical findings.
Dr. Michelle Hure, how are you?
I'm good. I'm good. It's so good to be back and talking to you.
You are my first guest on specialty stories, and so I think a lot of students watching this live now would love specialty stories because, right, it's learning about specialties. And obviously a lot of students are doing this now because of COVID and you can't go into doctor's offices and volunteer and do all of that fun stuff. But specialty stories is a great way to also learn some more information. Yeah. Dermatopathology. Yes. A lot of students are like, what the heck is that? It's like this like Frankenstein of a specialty. Like, where do you're making up all these words now?
Right? I know.
Tell me about it.
You know, there are actually even physicians that don't really know what we do. So pathology in general, actually, a lot of specialties don't understand what we do. And they're physicians, you know, and I really think that that's a disservice to our specialty and the fact that they're just not exposed to it in medical school. And that's a big problem. Because pathology in general is vital to almost every specialty out there. And it's good to understand what we do so that you have a better understanding of what we can provide to you and what service we actually can give you. Dermatopathology, and I'll kind of go into all the different types of pathology specialties, but dermpath is a rare bird in that you have to be really proficient in both dermatology and pathology of the skin. So dermato is skin. Dermatopathologists their board exam is by both the American Board of Pathology as well as the American Board of Dermatology, and half of it is pure derm path or pathology, and half of it is pure derm. This specialty of pathology, more than any of the others, is absolutely linked to clinical findings. So many times I wouldn't even be able to make a pathologic diagnosis unless I had the clinical picture, history, all of that. It would be a totally different diagnosis based on, say, the patient age or site. So it's vital that we have to know the dermatology, the actual clinical presentation, in order to make the pathologic diagnosis. And I think a lot of people see pathologists as just in laboratory behind a microscope.
Yeah.
But that's not really the case a lot of times. It's a stereotype, and especially for derm paths, it's definitely not.
Let me ask you a question, because as you say that, right, having talked to a lot of pathologists, one of the biggest things that they want primary care doctors and other physicians to understand is that they can't make a diagnosis just by staring at a slice of tissue. And they need that clinical history. They need the physician to provide that. And obviously, as a dermatopathologist, you're oftentimes the one doing both. Why is dermatopathology so special? Why don't we have GI path and oncopath? And like, why is there not a path specialty, subspecialty for every field?
Well, there is. I mean, there are a lot of subspecialty pathologists, and you know, as I'll go over kind of in my little talk, there you can subspecialize, and there are a lot of people that do that. There's GI pathology, there's neuropathology. I mean, it just goes on and on. But honestly, a lot of those, the subspecialized areas, they're usually handled by general pathologists. But there are a lot of places in academic centers that do that subspecialty, but they're not doing the clinical aspect of it, right? Correct. And most dermatopathologists don't. And I will tell you, most pathologists don't. Okay, there are some that do, but you have to have additional training for that. You're either a dermatologist or you're a physician that has had extensive clinical training. You don't get extensive clinical training in a regular pathology residency.
Yeah,
you are not mandated to do an intern year. You're not mandated to do any sort of clinical work with real patients, real live patients at least.
Yeah.
Yeah.
Interesting. All right. Well, I'm excited to jump into your presentation, see what we have rocking and rolling, and I'm sure the students want to really dig in and hear all about dermatopathology.
Okay.
So
All right, I'm gonna share my screen. So dermatopathology. And again, I'm gonna talk about kind of all realms of pathology, not just dermpath. So honestly, this is kind of what people think about pathologists, at least in the medical community, that we're all kind of these weirdos that, we're just like freaks in the basement. And that, like the mug said, this is not my mug, but I have several kind of like this. I like people that enter my microscope. But honestly, we are kind of weird. So when I was a kid, and because I guess I'm old, but my first introduction to pathology was Quincy. I don't know if you remember watching Quincy on TV, but Quincy was the best. Quincy was the best. Look at him. He was like on the autopsy table just reading. But, there's a lot of shows, and they all tend to be about forensic pathology, right? Yeah. That's like the sexy topic. Of course, my favorite, X-Files and Scully, who just happened to do autopsies, even though she wasn't a pathologist. But honestly, people, this is real life. We are kind of weird. This is like, our conferences tend to be lighthearted, and we're all kind of quirky. This was me doing an autopsy in residency, like having fun. But we're all just, very collegial. We're not freaks. We go out, we have a good time. Some of us are freaks. But what is pathology? So again, I get this question all the time, even from other doctors. What do you do? What do you do? We can be literal, like what does it actually mean, the study of suffering? But really, pathologists will look at the clues and make a diagnosis. So whether that's observing tissue, whether that's running a test, we basically will look at these clues to make a diagnosis. And clinical history is part of that. And that's the part where people don't understand. They don't want to like bias us. I know that's something that I've heard a lot, that, I didn't write the history because I didn't want to bias you toward a diagnosis. But this is how we make the diagnosis. We take all the information and we put it together based on, history, clinical exam, as well as what we're seeing or any tests that we're running on the tissue. And that's how we make the diagnosis. So the clinical history is vital. And in the end, we are the doctor's doctor. I know, like your last guest that used the surgeon. Well, pathologists are the doctor's doctor. So we're answering those questions that you need to continue with your treatment, to guide your hand. And without us, you don't really, have a treatment course. So that's really, fundamental, that people understand that pathology really is integral to every aspect of medicine. And honestly, I think it's one of the best kept secrets in medicine. It's not as competitive as, say, plastic surgery. It's probably not as lucrative as plastic surgery, but we can get into that later if you want to. But I feel that, this is kind of what I got into medicine for. I obviously take care of patients, but I also think it's an intellectually stimulating specialty, in that, I am not working off this cookie cutter protocol. I am working at my own pace to solve a mystery. And that's what I love. I can interact with people if I need help. I can, talk to colleagues. It's a very stimulating specialty. Also,
now, let me ask you, one of the biggest myths or misconceptions that I hear a lot in talking to pathologists is that you are down in the basement and there is no patient interaction. Talk about that side of the kind of myth of what pathology is.
So, to some extent, depending on the subspecialty, that could be very likely. Many times pathologists are in the basement. I happen to like the basement better. There's no sun. I don't have to worry about sunscreen, but because we're not as forward facing to patients, we tend to be relegated to areas, say, of the hospital that are, in the basement or off maybe off-site. And that's unfortunate, because really pathology should be kind of front and center, because you are integral to every specialty. And I loved, when I was in training, I loved it when certain teams would round and they wanted to see the pathology, so I could show them and I can teach them and they can understand. And it wasn't just a report. And there are some subspecialties that will actually be more patient facing. I definitely rounded or rotated in hospitals where the pathologist was the one doing the fine needle aspiration. The pathologist was the one doing the bone marrow biopsies. And there are some places that still do that, where the pathologist is the one and not the clinician. So there are still some places that will do that, but usually the pathologists are kind of behind the scenes, behind their microscopes, in their labs, and they are kind of disassociated from the patients, which is unfortunate, but that's just kind of how it is. But I feel like it could be something that could change, and even our own academy would like to see us more as part of the team, even rounding and that sort of stuff. It's just, it's hard. It's hard to do that when you're so busy.
And when you say academy, just for the students, you mean like the organization that kind of oversees all of pathology?
Right. So exactly. Our board, our College of American Pathologists, like the actual agency that we're part of. Yeah.
Yep. Got it. All right.
So I think what's awesome about pathology, which has a lot, in common with other more competitive specialties, maybe, is that work-life balance. Pathologists, they get in at 8 or 9 and they're kind of done by 5, 5 or 6. And unless you're on call, that's, your pretty predictable day. You have your workload, you have conferences if you are in the academic setting, and then you kind of wrap up for the day and you go home. It's not like you're like a surgical specialty where you're kind of always there. And that's really nice for people. And I think that's also why they're probably, it might attract more women. But it's nice to have that. You don't want to be married to your job. At least, I didn't.
Yeah.
I think that's important. The other thing is, pathology is very diverse, and it's not just the people. There are tons of different people. It's not just like, I hate to say it, but they're not all like jocks from like the ortho, or you know what I mean? It's not ortho.
Not all nerds in neurology.
Exactly. Oh my God. Yeah, totally. It's everyone. Like, you have people like me, you have, like foreign med grads. I am actually considered foreign med grad because I went to Ross, but from a different country. It's, as long as you have a pair of eyes and you can move your hands, you can do it, so you can have many different people, and it tends to be a much older person that's in medicine as well. I think like the oldest people I've ever seen, who are like 300 years old, are still practicing pathologists, like you were alive before there was like a microscope and you're still working, and it's possible. Like, it's seriously possible for that. The other thing is, you can work in many different settings, and that was really attractive to me. So if I wanted to be in the hospital, I can. I could be in an academic hospital, I can be a community hospital, I could be in a private practice, I could be solo, I could be in a small group, I could even work for biotech, I could work for the government. I could do many different things as a pathologist, and all the doors were open.
Cool.
Working with other doctors, I think, was very important to me. So my husband is a radiologist, and I love that sort of correlation with with radiology, with findings. You know, many times when I was signing out as a resident, like say breast pathology or GI pathology, I would always look at the imaging and correlate it with what I was seeing. And that's a big deal. So when it comes to say like tumor boards, and tumor boards is basically like everyone taking care of that patient, the oncologist, the radiologist, the pathologist, they all get together and they talk about the patient and what's the best, you know, way to go forward to treat them. And you have that integral part in helping them determine the best course of action and best course of care for that patient. And I loved that part of it. So you're not just isolated at your microscope looking at slides all day, or you're not in the laboratory, you know, doing blood banking or whatever aspect of pathology you're doing. You're integrated into the entire team taking care of the patient.
Yep.
And honestly, beyond any other field except maybe radiology, because they're doing a lot of artificial intelligence in radiology, and my husband's actually working on that. But the cutting edge technology and pathology is awesome. So we're doing so many things where we're integrating diagnostics and therapeutics, and it's really this targeted therapy, like individual to the patient, which is huge. It's awesome. And it's just getting better and better. And especially now that we're starting to get AI and telepathology, it's fantastic.
Yeah. That's awesome. When did you, a common question that keeps coming up is when were you first exposed to dermatopathology? So
dermatopathology, I was first exposed to it as I believe I was a 3rd or 4th year medical student. And I think I was a 4th year medical student. And I was doing rotations at UC Davis, University of California, Davis. And I did a dermatology rotation, which was fantastic. And I met one of the attendings who was also a dermatopathologist. And I started looking at a few cases, especially the ones that we would do the biopsies on so that I could follow through and look at to see what the pathology was. And I remember just sitting at the scope and literally falling in love. Because seriously, not with the attending, but with the slide, So
you couldn't see the slide because your tears were flooding like, the
oh my God. Yeah. So I remember sitting there going, this is the coolest thing I've ever seen.
Yeah.
And I was like, I liked derm. I think it was really cool, but the derm path was like amazing to me. And his teaching, he was a fantastic mentor. So that was when I realized like I wanted to do derm path. I mean, I love derm, that's great, but derm path was fantastic. And it was that marriage of both the pathology and the clinical medicine that was such a, big thing for me.
Have you always been someone, on some level, there's something about pathology where it seems like you have to be someone who just loves how things are put together, right?
Totally.
Getting down literally into the micro of things. Do you think you've always had that personality? And so when you were like, oh, like I can literally see how we are built outside of an x-ray and how bones get put together. Do you think that was part of it?
Oh, totally. Yeah. I mean, as a kid, I would take things apart just so I knew how they were and then put them back together again. Yeah. I was always the kid that was like asking why, how does this happen? Why does this happen? And that was something that, I didn't have that spark when I was going through, pre-med and med school. I knew I wanted to do something. I thought I wanted to be a trauma surgeon. I mean, we could always get into why I wanted to do that, but nothing was igniting that passion for me. And until I realized, oh my God, this is what I've been doing my whole life. I want to get to the root cause, like the nuts and bolts of the disease, of how things work and see it. And it wasn't until I sat down at that scope that I had that experience before. And it was really quite transformative. And that's when I was like, this is what I want to do. And it was awesome. Yeah.
Cool. All right. Let's keep going.
So I think it's important to understand what pathology is made out of. So there's two branches. There's anatomic, which means that you look at tissue, and that's what I do. And then there's a whole bunch of things under that, you know, all those different types of subspecialty pathology. None of those are really necessarily board certified, so you don't have to necessarily take a board in those general subjects. They're all just kind of part of the training. And then the ones that I list below it, those are actually board certified. You have to do specialty fellowships and get boarded in them. And obviously everybody knows about the forensic pathology, and we could talk a little bit about it. That's like the you know, most popular thing, which is really cool. I will tell you, while I was going through training, I fell in love with my forensic pathology rotation. It was in Boston Medical Examiner's Office. And I literally, even though I had my dermatopathology fellowship lined up, ready to go, I was like, oh my God, should I change? This is like, oh my God, I really want to do this. But then I just, you know, it just, we can talk about that. It just affects you profoundly to work in that environment. You have to be definitely a certain type of person to do that.
Yeah, we'll try to get Dr. Judy Melinek on, who wrote Working Stiff. Which
oh my God, that's so cool! You have her coming on.
We're gonna try to. I've had her on Specialty Stories. I'm friends with her, so hopefully we'll get her.
Oh my God! So then I don't have to talk about it. Then there's this whole other arm of clinical pathology that's more working in the lab, and that's really where this cutting edge, you know, technology also comes into play, where we're talking about molecular genetics and really this like targeted therapy, you know. So say someone has a lung cancer and we want to see, like, should we put them on a particular medication? Should we put on a certain chemotherapy agent? We're going to actually do molecular testing to see if that patient would benefit from it. That's more of this targeted therapy, and that's amazing in the world of, you know, oncology right now. What we can do to tell our oncology colleagues what the patient would benefit from, and I think that's a big deal.
Okay. Let's
talk about the residency though. So what is it? Like how long is it? What do you do? So there are over 140 programs. You know, some are pretty small, some are much bigger. I want to make this like a really big point, is that for some reason, American grads don't tend to go into pathology. And I tried to sort of figure out why that would be. Like, is it just because of exposure? Is it because there's some sort of stereotype against pathologists? I don't really know exactly. My guess is that it's the exposure, that as a pre-med, maybe you're not, you know, exposed to it as much, or even as a med student, it's not part of a core rotation.
Yeah.
So I don't know.
What about, I think a lot of people go into medicine for that hero aspect, right? I want to save people. I want to help people. In pathology, I don't think they're connecting the fact that they are saving and helping people by helping the team get to a diagnosis, the correct diagnosis that's going to lead to the correct treatment, which will hopefully help someone and save someone. I don't think they're tying it together. I think they see pathology doesn't equal helping people. It's helping dead people, I think, is what most people assume.
Right, which is funny because that's like such a small portion of what pathologists do. No, I think that's definitely part of it. I mean, I know when I started medical school, that I had the same thing. I wanted to help people, I want to put people back together again, all of that stuff. Pathology wasn't on my radar. Like that was Quincy, right? That was like autopsy. I totally get it. Yeah. But if you're in it for the fame and glory, you're going to get disappointed. And if you're in it for the medicine and you're in it to help the patients in any way that is meaningful, then it should really be a specialty that you should look at, because that's pretty great. It's usually about 4 years. I actually did a 3-year track that was just the anatomic pathology. I did not do the clinical pathology part of it. You can choose to do that. So it was only 3 years. There is not an intern year included, like I said, so you don't have to go through hell unless you want to, which I did. And most of your time in the first year, at least, is spent grossing. And I know people don't understand what that is. So you actually take, and I have a picture of it in a little bit, you actually take the specimen, whether it's bowel, whether it's a breast, a brain, whatever it is, and you cut it up.
Did you mean to have alliteration there? Bowel,
right?
breast,
Oh my
and brain?
God, no, I didn't, but that was really cool. And anyway, you cut it up in a way that will give you the most information and the best information to make the accurate diagnosis, and also give you other information like margin status. Is the tumor out? Lymph nodes, are the lymph nodes positive? So grossing is actually super duper important. It is also gross. Like it's disgusting sometimes. Literally, yeah. Literally. But it's also, I think, super cool. A lot of the times at big institutions, it's actually done by a pathology assistant or a PA, which is different than like a physician assistant. Yep. Their sole duty is to just kind of cut up the tissue in a way that gives the pathologist the information that they need. But residents need to know how to do it themselves because that's part of learning. A lot of your day is actually looking at slides and then signing out, which means sitting at a double-headed microscope with your attending, going over the slides that you've looked at, and then they ask you questions. You know, what do you think? What is this? What is this cell? You know, what is your diagnosis? And then you talk about it, and everything is a teaching point. So even on the most mundane slide, anything can be a teaching point.
Something to learn, definitely.
Something to learn. I love it. Of course, autopsy is part of it. In the current guidelines, every resident has to have, right now in COVID, 30 autopsies to actually graduate and take your board exams. When I was a resident, it was 50. We didn't have COVID. I think I had over 100 because if there was an autopsy, I jumped on it because I wanted to do it. It's like my favorite thing is to do autopsies. I know it's weird. So that's a big deal. And not a lot of people understand that autopsies are different based on where you are. So there's the forensic pathologist, which you'll learn about, and they look at cause as well as mechanism, like how it happened. Most pathologists in the hospital setting are just looking at cause of death. So they're not going to be looking at the things that a forensic pathologist necessarily looks at. They're not going to be doing a lot of toxicology and all that stuff. This is like medical death. So, you know, you're looking at everything, the brain, the intestines, everything. You're cutting it open, you're looking at it. And you're taking little pieces of tissue and turning it into a slide that looks like this. And then you're diagnosing what the patient had underneath the microscope. And then you write this big old long report. And it's so fun. The other thing is you guys probably learned about didactics from the last lecture. Of what that means is basically lectures. So kind of what I'm doing right now, talking to you about a subject, going over a particular subject. And in pathology, there's so much to learn. And even 40-year veterans, the more they know, the more they realize that they don't know things. And you're always learning in pathology, always learning, and in medicine in general. But there's always something to learn in pathology. Lots of conferences, like I said, so it's conferences with residents, conferences with different attendings, conferences with different fields, right? So there's radiology, pathology consensus conference, there's tumor board, there's so many conferences to go to that you're interacting with other people. And of course, you're also in the lab sometimes too, if you're the clinical pathology. So running the tests, learning how to run a lab, doing quality control, all of these things. What I thought was awesome about pathology is that you get time to do some research as well. And that's super important to, you know, get published, to really kind of follow through on what's interests you, and you have the time to do it. So that's what I loved about my residency is, if you want to do something, do it. Okay, put something together. We have money for you. Let's, run your research. Something that when I was a chief resident at UMass, I really wanted the residents to really get into the habit of basically being and attending, so that when they finish residency, they felt more comfortable being on their own. Because I noticed once pathology residents graduated, they were like, freaked out. Like, how do I, do anything? One day I'm a resident, the next time I'm attending, and like, I don't know anything. Like, surprise. And that's why a lot of pathologists will do multiple fellowships to try and get, comfortable. But I'm like not down for that. I want to do my training, and I want to practice. I don't want to stay in this like constant loop of doing fellowships to maybe feel more comfortable. I was really pushing for residents to get that graduated responsibility, to learn how to be an attending, to think for their own self, and really kind of be motivated to do that. Part of residency, of course, is being on call. And call means doing frozen sections, and not get into that kind of what that means, but that's a big deal. That's when the surgeon's in the OR and they have a tumor they're trying to resect, and they want to know if they have it all out, and they'll send it to you to tell them, do I have negative margins? Do I need to keep cutting? This is a big deal when it comes to things, say, like brain tumors, or, Whipples, which is basically taking out like your pancreas, for pancreatic cancer. This is a big deal. And they always take the credit, surgeons do. I don't know if anyone has questions, but
keep going. We got lots of ones that we've covered already, or things we can pick up as we go.
Okay. So, I get I'm on Instagram. I don't have a huge following, but
you will now.
Oh God. But I get a lot of people sending me, direct messages. How do I get in? How do I do that? How do I get Dermpath? And so what's a good way to start out? Well, first of all, you're not going to be a strong applicant if you have no prior experience, you have nothing showing that you have any real interest in pathology, and people are going to see it as your backup.
Yep.
And that's never a good thing. And so how do you get some sort of, get involved at all? So you can definitely go into one of the pathology societies and sign up. And there are a lot of online things now, and it's tough because everything is online, and it's hard to sit down across from like a mentor and look at slides, or go see patients, or it's really hard. But you can do what you can, online tumor boards, even contacting a residency program, and maybe even getting kind of matched up with a resident that you could at least talk about things with. Go to their online presentations, and hopefully we'll be able to go in person at some point soon. And then if you were necessarily able to, like, say if you're a pre-med where you have a medical school at your institution, or you're a med student, try to rotate, do some sort of rotation in pathology. There used to be something called a post-sophomore fellow, which as a medical student, you actually take time off after your sophomore year, your second year, and you do a year of pathology. And a lot of the times it was actually like people who wanted to go into surgery who would do that. So they had a better understanding of pathology, which is integral in the world of surgery. One of our post-sophomore fellows at UMass was actually fantastic, and I think was just as good as if not better at diagnosing things than our first year residents. And it's a fantastic way, if you wanted to take time off to do research, to get experience, and it might even get you a good specialty, like say plastic surgery or general surgery or something like that, or of course pathology. But this is a great way if you rotate just to get those letters, to get some sort of exposure, so that a program will say, okay, they actually are serious about pathology, and it's not just, you know, a backup plan. So what do we do? So what happens to that specimen once it's taken out of the body? So this is the grossing table, right? It's gross, it's disgusting. Basically, you have someone who is cutting the tissue up, and this is probably a PA. They're dictating. Can you guys see my cursor when it's moving?
Yep.
Okay. So
the
person. Okay. I don't know if everyone else can. So they're actually dictating. They're saying they're giving detailed measurements. They're talking about the color, the texture, what they're seeing. These are all very important things. You will even take pictures of the specimen as well, so that, you know, the surgeon knows and it's documented if it's a very interesting case. The pathologist who's signing the case out knows what it looks like. And you describe it, and then you cut it up into little tiny pieces about the size of a nickel in each of these cassettes, and you put it in formalin. The formalin
Do you
is
ever get used to the smell?
Yeah, so yeah, you do. Obviously you shouldn't have very much of it. It is a carcinogen. I will tell you
not
though,
of formaldehyde, but just of the gross parts.
So you get used to it. I mean, you get used to anything, right? Most of the time it's coming to you already in formalin. So you're not having that like strong blood and all this other gunk smell. It's mostly the smell of formalin. And you're working in a hood.
The alliteration going with blood, bowel, and bile.
Right? Totally. The other thing is you are working in a hood. So this is actively, this area, this grate is pulling up all of that formaldehyde or formalin and the smell. So it's not that bad. It's kind of like it's working in a fume hood almost. Yeah. But yeah, you never really get used to it, but enough, right? I will tell you though, as a side note, I used to teach anatomy when I was a grad student and actually as a med student as well. And the smell of the formaldehyde is actually an appetite stimulant. I don't know if you knew that.
Oh yeah, we would always
go.
We would always go out for dinner after hanging out.
Oh my god, I would always get so hungry for shredded beef. I know that's horrible to say, but it's serious. So, and this is probably why in pathology, pathologists love equating what they see in terms of food. I don't know if you know that, but if there's a lot of pathology terms that revolve around food, and I have a feeling it's because of that, like formaldehyde, it makes you really hungry. I don't know. I'm already getting hungry thinking about it. Yeah. So you put the tissue in these cassettes and you actually put it in a tissue processor. This is important to know because it takes a while to get your pathology report. And people always want to know, why does it take so long? Because they think it's like a blood test. You just like throw it into a computer and it spits out the answer. Mm-hmm. Not the case. It takes time. It takes about a day to fix the tissue. It takes a day to do the tissue processing, where you're actually, the processor is exchanging the water that's in the cell, and it's going through a series of changes where it's changing it to alcohol and different concentrations of alcohol. And then it's putting paraffin in there. It's actually wax, so that you're able to make this tiny, tiny, tiny little cut. You embed it in wax as well. And then you cut it with something called a microtome. And it cuts the tiniest, thinnest ribbon. And it's actually about 4 microns. And if you don't know what that is, your hair, one hair is 50 microns. So it's doing the tiniest. So it's 1 cell thick. And that's what you're looking at when you're looking at a slide. You're basically looking at 1 cell thick. And this is what it comes out looking like after you stain it. And that's where you make the diagnosis. So it takes a while to do that. So what do you do once you get the slide? Well, that's the microscopic examination. I call it pushing glass, and that's kind of like the street name for it. What do? You make a diagnosis. The diagnosis we talked about is based on the history, the imaging. Many things make you, bring you to that diagnosis. And what does it mean? Well, it can give that prognosis to the patient, right? So say in melanoma, it's telling you, what type of melanoma you have, the stage, the grade, and then it's going to guide that treatment. And theranostic studies, that's like basically the diagnostic and the therapeutic coming together for targeted therapy. So here, you gotta love pink and purple in pathology, because that's like your world. It's called hematoxylin and eosin, H&E. So that's like your, that's the standard. That's what you get. There's always other things you can do, other stains you can put on later. Those are all special stains, or immunohistochemistry is what it's called. You're actually staining the slide to look for particular antibodies or antigens. But this is a typical glioblastoma multiforme. I don't know if you've ever heard of that, a brain tumor. And this is melanoma, and then this is a GI or gastrointestinal polyp called tubular adenoma. So this is the awesome part, which I loved to do as a resident, was frozen sections. This is when you're on call. And the surgeon is sending down a piece of bowel and there's tumor in it. And he's like, I want to know if it's free, if it's clear, or all right, so I can, close the patient up. And so they send you this piece of tissue and they throw it at you and they say, tell me. And you're like, okay, cool. We need to know if the tumor is out, because this is the surgical margin. And this is what you do all day when you're on frozen section service. You're just telling people either what type of tumor it is, and sometimes they don't know, and they're sending it to you for an actual diagnosis intraoperatively, or they ask a question, is it out, so I can close the patient. And so it's really cool. You take a little section here. This is the tumor. This is the margin. You mount it on this block. You cover it with a media that freezes, but keeps the cells from the actual cells themselves from crystallizing, so that it would look weird under the microscope. The water keeps it from crystallizing. And then you cut those tiny sections off of the frozen tissue, and you immediately look at it. So this is different than that long process that takes like a couple of days. This is quick and dirty, and it also looks quick and dirty, so it's not like beautiful histology on the slide. So it's a little bit harder to sometimes to interpret, but it gives you your answer. So not everything can be a frozen section. So I'll just do a little bit on ostomies, so that I already kind of went over a little bit already, but I know that you're gonna have someone else on there. Like I said, my favorite. It was honestly my favorite. This is my shirt, the dead to teach the living.
Nice.
So this is really where most pathologists that work in a hospital will do autopsies. And I think that it's important to know that it is a small portion of your daily duties. And it may only be like every other month that you're on autopsy service, but it's definitely part of it, but it's not everything that we do. It's a very small portion of pathology, unless you're a forensic pathologist. So I do have one autopsy case that that's like the hospital type of case. And so this is what we would see on a typical autopsy service in the hospital. Young woman dies during surgery to move clinically diagnosed giant hepatocellular adenoma, and adenoma is considered benign, okay? No other risk factors, okay? All of a sudden dies. An autopsy is going to be performed in that case. She's young and sudden death. And this is what I love about autopsy, is that you're answering that question. Like, you're getting down to that root cause. You're going through everything, and you're finding, this finding. Many times in autopsy, we don't have a finding for the death, and it's sad, but most of the time it's just like, heart attack or arrhythmia or who knows. But in these circumstances where we actually can find an answer, it's so gratifying. In this case, she actually didn't have an adenoma. She had a hepatocellular carcinoma. And then she had little emboli that went all into her vessels. and they just caused massive infarcts everywhere, and she died from that.
Is there a specific reason why this happened while she was undergoing surgery, or do you think even if she wasn't undergoing surgery, this potentially was going to get triggered?
It was potentially going to be triggered anyway.
Yeah.
So I don't know if anyone wants to know like how I got to where so what's my path? So I was at UC Davis. I was like a super senior because I did dual majors. I don't know why. Shouldn't have done that. I was like, okay, whatever. So bio-sci and poli-sci. And I got into research while I was there. And I wanted to continue that research. I was actually on a grant from the US Navy. I worked with marine mammals and doing virology. It was really cool. And I stayed on and I did a graduate school there. And then I even was like a medic on the ambulance because I was like, let's do this. It sounds like fun. And then finally I was like, okay, I want to go to med school. I always knew I was going to go anyway, but I was like, now I'm ready to do it. And then of course I only applied to like Davis and then didn't get in. So I ended up going to Ross, which I thought was a great experience.
Yeah. And so for those of you watching this or listening to this, Ross being a Caribbean medical school, considered an international medical school, typically doesn't set a lot of people up for success. And yet here you are, a dermatopathologist, doing what you love.
You know, it's all what you make out of it. So I thought my experience on the island with the first 2 years of med school were probably just as comparable. I mean, part of my graduate school was taking med school classes. I knew what was out there. I was teaching, you know, anatomy. So I also knew the type of students. I thought it was absolutely comparable to the first 2 years. I ended up setting up all my own rotations after the first 2 years because I wanted to be in good places for my clinical experience. And I think that was the key for me. So most of my time was at Yale or UC Davis. And if I had gone to wherever Ross was going to put me, maybe it wouldn't have been the same, wouldn't have had the same contacts, but that I was able to make. But that's not a normal thing. I mean, we can always talk about like Caribbean med school and all of that. I thought my Ross experience was good. So I was happy with it. I ended up doing internal medicine here at one of the Yale hospitals, which was fantastic, St. Mary's Hospital. And then I stayed at UMass for all the rest of the time. So I did my residency and fellowship there and then flew out to California the day I finished because I didn't want to be on the East Coast anymore. So like we said, derm path, there's really two ways to get there. You can come from derm, you can come from path. And if you come from derm, you're basically always going to be looking at slides in your fellowship because you need to catch up. And sometimes you're not even just looking at derm path slides, you're looking at, you know, say breast pathology, you're looking at, you know, GI pathology as well. You're not going to become proficient in that, but you also need to be exposed to it. Yeah. If you're coming from anatomic pathology, then obviously you're going to be more focused in all of derm.
Yep.
So a typical day, I'm looking at slides. I'm also in the clinic. Let me look at you, get naked. Pathologists, dermatopathologists also, you know, we help out with, say, Mohs surgery. We're looking at the slides, and Mohs surgery is performed by Mohs micrographic dermatologic surgeons that do fellowship training, and they cut out skin cancer, and they do it in a way that's very precise, and at the same time they're doing frozen sections on that tumor, and they keep cutting until they can see all the tumor is out. And then they close it in a very beautiful way, like a plastic surgeon would, probably better. And then you're able to go home, and it's all the same day. And that's really the best cure rate for a lot of the skin cancers out there. One of the things that is my favorite thing to do, though, is teaching the residents and med students about pathology and derm path in particular. So this is, I'm also an assistant clinical professor of dermatology at UC Irvine, and I love teaching the residents about derm path, especially when they come to me with a case that they've seen in clinic, and then I'm able to show them and correlate with them, you know, what they saw in clinic on the patient with the pathology and really bring it home to them. So I have cases if anyone wants to see any cases.
Let's do. I'm gonna ask if you want to come on and speak with us and try to answer some of these questions. We can get you on. So raise your hand. And again, there's a little bit of delay. And as that is happening, Brian just said, "This is such an awesome experience. I'm now interested in pathology, which I wasn't before."
Oh my God, Brian, that's awesome. That's awesome. By the way, so on Instagram, I'm at OC Skin Lab. Feel free to send me any messages if you have any questions, if I can help you out, if you know want any sort of input or anything like that, just let me know.
All right. So I just added Mariana on to the stream. Let's see if she can jump in. So go ahead and
so case one, they're pretty fast cases. So case one is a 47-year-old male who came to me with a new onset, just mildly itchy rash. No one likes to use the word rash, by the way, it's dermatitis, but we'll put rash for now. Sent by his primary care doctor. So patient is otherwise totally fine, good health. So when this patient comes in to you, what are some questions you might ask?
So Mariana, you are here. What questions would you ask?
I would ask if he has come in contact with anybody with another skin rash that looks similar, or if he's traveled outside of the country.
Excellent questions. Excellent questions. Those are fantastic. Anything else you'd like to ask?
I guess I would take like a history, and I would be curious about the patient's history if it's like a recurring rash.
Yep. Perfect. Yeah. So I think those are awesome. I always kind of start at the top. So how long has it been going on? Right? So you always want to know the timing. Is it brand new or has it been there forever? And then you're going to want to ask those questions, like what could have brought it on? So medications, new medications, and medications that they're already on. This is a big thing in dermatology. A lot of people will say, well, I'm on this medication forever. It's never had any problem before. But not every medication has to be new. It can be an idiosyncratic reaction. It can happen anytime. It's not dependent necessarily on the duration that you've been taking it. Many times it is, but not always. Anything new you've put on your skin? And then has anything made it worse or better? Are they putting anything on it? And like you've already said, has it happened before? Any travel history? And I think this is very important too. Any sexual partners? I think that's also important. Cool. So in this situation, I won't necessarily tell you exactly what the answer was until we go through this. So I ended up biopsying, and I think this is important. So you need to understand what a biopsy is. And I'm sure most people have heard about a biopsy. Basically, you're taking a little piece of tissue. You can take a punch biopsy, which is like a little cookie cutter cylinder of skin out, where you're really looking at all layers of the skin, the epidermis, the dermis, the lower dermis, and then the fat underneath. So it's really important when it comes to like lesions that are considered inflammatory, like a rash, like a dermatitis. It's very important to see everything. Or you can just shave it off, and that's a shave biopsy, or sometimes a scoop biopsy. Really good for things that are sticking up, and you can just kind of cut it out like that. Okay, so I was very lazy on this case because it was the end of the day add-on, and I was like, don't have time to do a punch biopsy and put a stitch in. I'm going to be quick and dirty, and I'm going to get underneath it, and I shaved it. I'm sorry, I know this is really bad. So this is, I don't expect anyone to understand what this means. It's a lot of pink and purple, and this
beautiful.
It's beautiful, right? And this is ink on the bottom. I always ink my tissue to know where the bottom was, where I cut out. So this is the top layer, which is called the stratum corneum. This is what flakes off, kind of, that's your dry skin, sort of. This is the epidermis, that's the top layer of skin. This is the dermis. And all of these crazy blue cells in there, that's inflammation. These ended up being plasma cells. I don't know if anyone has heard of a plasma cell. I know, sure you have, but it's a type of immune cell. And so the plasma cells are all over the place. And whenever I see a brand new rash in someone who has a new sex partner, so that was the history, I always think of something called syphilis. Yay! So,
yay, syphilis.
yay for syphilis. It's making a comeback. And so all these little red things here, this is a specialized stain. This is an immunohistochemical stain, which basically means that the stain is attaching, it's like an antibody going to an antigen, and then it has a little chromophore or something that changes the color when it does bind, and then it produces that red color. That's the dye on there, and that means it's labeling all of those little beasties in there, and those are the treponemes. That's syphilis. Oh. That is awesome. And
wear your condoms, folks.
Well, yeah, and then of course, this is pre-COVID, by the way, and I shook the patient's hand. Not that I'm going to get syphilis. They did not have active lesions on their hands. Even if they did, it would be very hard to get it that way. I would really have to like get some friction going, which I'm not going to. So it was safe. I'm not going to get syphilis from touching. But that's like a typical sort of case that I get. And I see patients in the office, I do biopsies, but I also get a lot of biopsies from other people in the community, whether they're primary care or dermatology, doesn't matter. So they'll send me their biopsies from my interpretation. So I will do both. Okay, and now this is a patient that came to me, an older gentleman with about 4 months of this persistent dermatitis or rash. Okay. He is on a lot of multiple medications. He's older. Usually it's like, hypertension, that sort of stuff. Being treated by his physician assistant for about 4 months for what was considered ringworm, which is like a fungal infection. I don't have any like real questions on this one because I wanted to kind of get through it, but it's not ringworm. So
really? After 4 months? Sure?
Right? Hello. So, I mean, I am not going to get on the whole like doctor versus, PA thing, but if it's not working, maybe there's a reason. So we need to address that. Is it actually an eczema? Is it actually something else? And I did a biopsy in this case. Again, I don't expect anyone to understand what the hell all this means, but you have, again, epidermis, you have the dermis, and you have all these little cells. I promise you it's not another syphilis. So all these little cells are going up into the epidermis. And when you get really close and you look, all of these are lymphocytes, and they're atypical looking lymphocytes. So there's a problem here with the actual lymphocytes themselves. This ended up being, a cutaneous T-cell lymphoma or mycosis fungoides. So if something is not working, and a lot of people who may be on this call who are going into, say, primary care of some sort, it's very important to either biopsy or refer out for biopsy or evaluation from dermatology if you have something that is suspicious or not getting better. If you just kind of stay on it and not get an answer, and you're just throwing medication, topical medication on it, one, it may change the biopsy, so it's harder for a derm path to make a diagnosis, or you're going to be missing something like this, which is actually a cancer. It's a lymphoma. So, not the best. You always want to be more proactive. Okay.
So a student looking at that, and I have this question. I look at that and I go, well, that looks almost exactly the same as case one. How the heck can you tell the difference between those? Yeah. Is it just different stains and you look closer and like you're really picking apart the nitty gritty?
So you go to residency and you realize that the cells, the lymphocytes here, they tend to be more darker, atypical, like shaped. They're also lining up in a way that should not B. And of course, I am not going into the full picture, right? But you do other stains to make sure that they are aberrant, so that they're atypical sort of lymphocytes. So there's immunohistochemical studies that we do. We send it for molecular study as well to make sure that it's called a monoclonal, which means it's all one clone. So all of these lymphocytes are kind of coming from one lymphocyte that has freaked out and become cancer, and then it multiplies. So I can make this diagnosis without all of those necessarily, because it does look bad. And I maybe just do a couple of stains to figure it out. I don't always have to do a molecular, really expensive study, but a lot of people do, and you can, and that's a confirmatory thing. In this case, I did a couple of stains, and I didn't need to really go over the top. But again, it's looking at thousands and tens of thousands and cases and going over it with your attendings. This is part of your residency. Okay.
Practice makes perfect.
Now, yeah, exactly. This is super important, I think, for everyone to know, even if you're going into Path, you're going into wherever you're going into. Okay. So this case, I don't know. There you go. A 31-year-old lady who with a recurrent pigmented lesion after it was removed by an esthetician. Never good. Okay. Never let anyone other than a board certified physician take off anything that's pigmented. It's really disconcerting what I see in the community. I see people who have no training taking things off that should not be taken off like that. Yeah. Okay. So of course I biopsy it, and it ended up being a melanoma and with positive lymph nodes. This is all too common. And it's not just this random esthetician that takes it off with her little device that she got online, but it's also, not necessarily primary care doctors who think that, say, it's a benign lesion and they freeze it, thinking that it's like this, called a barnacle or something like that. Mm. And then lo and behold, it comes back and it was actually melanoma. I've seen that many times. So again, when in doubt, if you are going into primary care, it's very important to refer out or biopsy it yourself. It's really not hard. Part of what I do also is going out in the community for primary care doctors who do want to do biopsy and they want to know how to do it. I will show them how to do it. I will show you how to do it, because it's hard sometimes to get in to see a dermatologist. And a lot of the times, at least in Southern California, they're busy doing Botox and all the other cosmetic stuff. So it's hard for them to see, to get in to see the doctor for a skin check. They're usually seeing their nurse practitioner or PA. And I have seen these things missed. And I'm not saying that they are bad. I think they're great. But I have seen these things missed very often, and it's unfortunate.
And you made a point to say pigmented lesion. Now I'm assuming kind of the melanoma part is here, is the pigment is from melanin, right? Mm-hmm. The things that gives us a tan and right. All that fun stuff. Is that where the kind of pigmented lesion is the worry?
Yeah, and it doesn't, you can have an amelanotic or not pigmented lesion as well. So that can be tricky. And I think many people can miss those, not just, a PA or a primary care. But basically, you're more likely to get the correct diagnosis if you do see someone who sees these things all the time. Like I said, doesn't have to be pigmented. And even if it's pigmented, doesn't necessarily mean that it's bad. We look for certain things, certain characteristics to biopsy if it's higher risk, but definitely doesn't have to. What's that?
The ABCDEs.
ABCDEs, and I like to add F to it.
Oh, F now too.
F, yes, I like to give an F. It's funny looking, so it's different than the ugly duckling. So it's different than the rest of the moles. It's very important. Okay, maybe one last case. I don't know if anyone wants it. Okay.
One more.
45-year-old female with new onset lesion of the belly button. Funky looking. No history. You want to know the history, right? So when this patient comes to you, is, have you ever had anything else, any other cancer, anything else internally? Of course, all those other things that we went over, right? Duration, anything new, all this stuff. Is it itchy? Is it painful? This ended up being a metastatic breast cancer. We already knew the patient had breast cancer. This is a Sister Mary Joseph nodule. I don't know if you've ever heard of that before. So it's a metastatic lesion that goes to the belly button. It's really cool. Anyway, it's sad. It is really sad. It's metastatic breast cancer. But again, this is also why dermatopathologists that are coming from dermatology also tend to need to get a little bit more training in more the general pathology, because they may look at this and not know what it is because they're not coming from a pathology background. So they don't know. If I was looking at this, I mean, I would stain it maybe, but I know that this is breast cancer. So not everyone is going to have that background unless you're a path trained. But you can throw some stains on it.
What's the physiology behind breast cancer going to the umbilicus?
The skin. You know, that's interesting. So it's not just breast cancer. It can be any cancer that goes to the belly button. I don't know exactly if there's like some remnant there that's like it's tracking along there. I'm not really sure. It's usually it's not always breast cancer. A lot of times it's like a GI tumor, but
it's not a pathognomonic lesion.
No.
Yeah.
No. But metastatic cancer to the umbilicus is that Sister Mary Joseph nodule. That's like the other name for it.
Awesome.
Okay, this is me. This is my getup when I'm in the clinic. This is my papper. So I was wearing like a respirator to see patients and going home every day with a migraine. So I ended up getting a papper. I was on a long wait list for it. And I'm super duper safe when I see my patients. This was my Dolly Parton challenge that I'm pretty sure I won on Instagram.
Love the Tinder one.
Right? And then these are like some great path-based Instagram accounts to follow.
I Heart Histo. You don't have I Heart Histo on there?
You know what? I didn't put I Heart Histo. I should. I'm sorry. I left it off. I should put it on right now.
I love I Heart Histo. Unless there's some like evil like conflict between you two, and then I won't.
There's no rivalry. Let's start this rumor.
You know what I heard? No.
Yeah, right? Oh my God.
Very cool. Well, hopefully some more students are interested in pathology. We need pathologists. We need that part of our physician force out there. So hopefully some more people like Brian, who mentioned earlier that he's interested in pathology, that more people are going to come. That's my hope.
Let me know if you have any questions. I'm always around. I'd love to help out students.
Awesome.
Okay.
Well, Dr. Hure, thank you so much for your time today and sharing your knowledge of dermatopathology and all of these fun slides, and your Dolly Parton challenge there was awesome.
Thank you. Thank you so much for having me on, Ryan. It was awesome.